It's my pleasure to introduce Dr. Jerry Bouquot. Dr. Bouquot received his DDS and MS degrees from the University of Minnesota with postdoctoral fellowships to the Mayo Clinic and Royal Dental College in Copenhagen, Denmark, as the recipient of a Career Development Award from the American Cancer Society. For almost 2 decades, he was professor and chairman of the Department of Oral and Maxillofacial Pathology, West Virginia University. During that time, he received West Virginia University's highest teaching award and that university's highest award for service to the state. Jerry is now the Director of Research for the Maxillofacial Center for Diagnostic and Research in Morgantown, West Virginia. He is also the Director of a large national biopsy service, Head and Neck Diagnostics of America. He has been the Dental Director for the state of West Virginia, a Senior Visiting Scientist of the Mayo Clinic, a Special Advisor to the National Institutes of Health, and an honorary member of dental informatics at the University of Göteborg, Sweden. He is a professor of dental medicine at Capital University School of Integrated Medicine in Washington, D.C., an adjunct professor in the West Virginia University Schools of Dentistry and Medicine, a fellow of the International College of Dentists, and a fellow of the Academy of Dentistry Internationale. Dr. Bouquot has more than 180 published papers, abstracts, and book chapters. He has presented more than 1,100 research and continuing education seminars and courses worldwide. Unfortunately, due to the introduction, we have no time for Dr. Bouquot to speak. No, we do. Thank you very much. With pleasure, Dr. Bouquot. Thank you.
Okay, I'll start with my disclaimer. I do not have any financial interest of any product in my talk or with any companies offering grant monies for this CE educational course. It's been interesting. It's been quite a while since I've spoken to this group, and I recognize so many faces, but I'm trying to tie the names. Many of you send biopsies to my service, and I recognize your name, but I don't see your face. So if you do recognize me, please come up and reintroduce yourselves to me. I would appreciate that. And there are a few corrections. I guess they used a little bit older introduction for me. I am now at the University of Texas and in Houston. The new dean there 4 or 5 years ago, Kathy Flights, is an old friend, and I was, as most of you know, happy as a bug in a rug in West Virginia. I've always loved that state. But she was very persuasive and appealing in her plea to get me down there, and so now I'm chairman of Diagnostic Sciences at the University of Texas, and I've moved my biopsy service to the University of Texas. The department I have has about 31 faculty and about the same number of staff, so it's a bit like herding cattle. No, it's more like herding cats to try to control all of them. But we really, I would rank that department probably one of the 5 best in the country. So it's an honor and a privilege to be working there. I have put a few things on the screen. Most of those have been discussed already, but I just wanted to show you one of my favorite pictures. My son, oldest boy up above, I grew a beard in honor of him when he was born. I was a resident. Oh, I keep forgetting. I have to point this to the screen. And when he got a little older and grew his own beard, I decided to grow another one. So there's a bit of difference in the before and after shots. And anybody who's been in West Virginia, especially in the fall or the spring where the dogwoods are in bloom, realizes what a beautiful countryside it is. Tourism has become the second largest industry after coal, and they expect coal to be surpassed in about 10 years. And I think that's worthwhile because we have so many big cities, and this is such a nice place to visit. But my house is under the arrow there, and literally you can't see it if you fly over it with a plane. That's how much in the woods I lived. Or as people in California put it, how much in the firewood I lived. And of course, one of the things I've always loved is science fiction, and The Hobbit. I considered West Virginia, and still do, the land of the hobbits. And of course, I've come to a whole different place. But I'll never forget my roots. I spent 30 years in Minnesota, 30 years in West Virginia, and now I'm in my 5th year in Texas. And it's good that I had my Minnesota upbringing because I'm used to 5 months out of the year having really miserable, lousy weather. And Houston has that very hot and humid, and so I just stay indoors during the summer like everybody else. I don't think I could have gone to a more different place. The Texas Medical Center has for years now been the largest medical center in the world, and it is about to double in size over the next 8 or 9 years. We're creating a second campus. That campus is down about 3 blocks south of this building. We're looking north right now. Houston is in the background. I live over in these trees. But the medical center is almost like a cancer in this part of the city. It's just always growing. And the MD Anderson Cancer Center, which is the premier worldwide cancer center, is probably the biggest cancer in the group. Every year they're building another 14-story building and taking down one of the buildings that used to belong to us. So we're all moving to the next campus. But there are only 3 blocks separating the 2 campuses, and so I'm sure that in a few years that will all be combined again. We are right in the middle of it, and so the dental school recently got legislative approval, $135 million to build a new dental school on the new campus. And of course, MD Anderson is all around us. The 2 first buildings were MD Anderson and the dental school. And the medical center, the idea for that came from the dean of the dental school and the head of MD Anderson, who were good friends. So there's kind of a strong dental connection there. I was asked to give a talk on something near and dear to me, but of course, ischemic bone disease is a topic that I really love to work in. It's very, very frustrating to work in because there's so little known, and we have so many people who seem to oppose any idea or any concept of ischemic bone disease without really knowing what they're talking about. But I do have a broader interest. I talked to a few friends a long time ago, back in the early 90s, 3 younger guys into writing a textbook to replace the old Schaefer, Hein, and Levy. And by 1995, they had done it. I'm only on it because they wouldn't do it unless I helped. So I'm the 4th author. But Brad Neville, I'm really proud of him. He was one of my students at West Virginia University. He's now the chair at South Carolina. And this textbook just came out in the 3rd edition, and we were told by the publisher that it probably represents about 90% of the oral path market worldwide. And it is a good learning as well as an encyclopedic book that you have on your shelf. I'm very proud of that particular book, and I can say that because I'm just the last author. Also, some of you know that if you have any oral path interests or topics, I run the oralpath.com site. I have to admit it's 4 years out of date because I've been so busy at the University of Texas I haven't had a chance to do much there. But I am setting my goal to update that entire site this year. Well, let's talk a little bit about chronic ischemic bone disease. It is a disease that is something that was probably unheard of by medicine as well as by dentistry, outside of a few specialty areas before 1970, maybe into the 1960s, the mid-portion. And of course, the specialty area in our field would be osteoradionecrosis. We've known about that since we started using radiotherapy. And you probably are aware of the fact that osteoradionecrosis almost never occurs in other bones. It's only one of our jawbone problems. And there's perhaps some reasons for that that I'll get into a little bit later. Rather than giving a strict NICO talk, I've decided to expand this a little bit and sort of talk about the whole spectrum or family of diseases that are related to ischemic damage in bone. This happens to be a reported case from 1990. Somebody donated his head to me and he died, and his wife was kind enough to make sure I got it. And it was a golden opportunity. He was somebody who had been in intense pain, couldn't even get out of a chair for 7 years. And a couple of endodontists happened to notice some funny x-ray changes and decided to do some surgical removal. And after removing 3 of these sites, he was out of pain and was pain-free for about 4 or 5 years until he died for other reasons. One of the problems with chronic ischemic bone disease, regardless of the bone involved, is that the radiology is so nonspecific, often so nonspecific. Sometimes it's obvious if there's something wrong in that area. And I'll get into that in a little bit more because that's not just our problem, that's the problem for the radiologists as well. And it's kind of interesting as time has gone on and computerized MRIs have become so sophisticated. there are, this disease in the hip and knees right now is probably at least 95% of the time being diagnosed with MRIs, not biopsy. With the other bones, we still need biopsy to prove the diagnosis. But we've come a long way in the 20 years that I've been working on this disease. And of course, this is just a close-up of this area of mush. There's no cortex at all over this area. And you can see this brown, glistening destruction of the bony wall around the nerve. There was no bony wall at all. The nerve was just sitting in this gelatinous mush. And as a matter of fact, one of the ways that osteonecrosis occurs and is most severe is in somebody who's starving or has starved to death. And if you cut into any one of the bones in that skeleton, you will find gray jello. The entire marrow turns to gray jello. They call it gelatinous marrow. And it is a end-stage process. And here I think is a little example of a small part of that. And of course, what I didn't realize when I got into this that this was supposed to be a religious movement. You have to believe in NICO or not believe in NICO. And it's kind of silly because ischemic bone diseases have, in the past 30 years, come into their own. They're well established. They're responsible for a large amount of surgery and replacement of hips and knees. And our job version is just another variant of that whole thing. It's not the exotic, really different, unique disease that we originally thought it was going to be. Bone just happens to be particularly susceptible to a slowdown of blood flow through it. That and the brain, for different reasons, of course, are the two most susceptible tissues in the body to ischemic change. And of course, because this is in the jaw, we get a lot of secondary or sometimes primary inflammatory changes as well. But that's, nevertheless, the ischemic problem seems to be the major problem. But, you know, if you're going to be religious, I went to, when I couldn't find much help with my colleagues, I went to the bone guy in Oral Path, Chuck Waldron, chair of Emory University, old Minnesota guy as well. And I showed him a bunch of NICO slides in the early days. And he looked and looked and looked, and he didn't say anything for the longest time. And he finally looked up at me, and we were friends, so he could say this. He said, "Jer, I've never seen this in my entire life." But he sent me a letter saying, I don't know what it is, but it seems to fit best with osteonecrosis. And I went from there to truly probably the 6 world authorities on osteonecrosis of the hip, and I spent up to a week in their offices trying to get a handle on this stuff. And histology, when I talk about this disease or make a microscopic description or diagnosis, it's based on the hip literature, really. That's where most of this has come from. But still, one of those experts was Don Sweet at the Armed Forces Institute of Pathology. He was the chair of the bone section there. And I went and gave a half-day seminar over there to his group, and I showed this case. We had just gotten these pictures, and I showed it to him last, and he said, if you would have put that on first, I would have said, this is osteonecrosis, pure and simple. And for a very experienced guy to be able to say that meant that I really should probably put this picture up front. And so that's why I'm doing that. But there is, these are cadaver cases. This particular one was donated, but I've had over 90 mandibles given to me by 2 of the medical schools in West Virginia, and I've processed those in the same way, just to get a bit of a comparison. And normal is quite different looking and quite much more solid, and even the nerve doesn't have that brownish, glistening, gelatinous material around it. Well, if we talk about chronic ischemic bone disease, we have to talk about maybe one that has an acute episode, the dry socket. But this is really the list that you're talking about. NICO is just the tip of the iceberg. And for those who don't know, I think I put, okay. I should explain, for those of you who aren't familiar with the term NICO, it's neuralgia-inducing cavitational osteonecrosis. It's a name I made up in the 80s because I wanted to emphasize the 2 most salient features of this, and the ones that were the strangest. And one is the pain that's produced is way out of proportion to what we see in the bone. And number 2, it produces hollow spaces. And After a year of bone pathology, I realized, or I knew that you don't get hollow bones in humans unless you have some kind of blood flow problem. That's the only way it can happen. So I put that name on thinking, well, we'll give it a new name, then all this controversy will be over and done with. And of course that doesn't happen. I just went through a 5-week trial in California where some of the Quackwatch guys were trying to prove that NICO didn't exist. And in 5 weeks there was not a single piece of evidence presented. It truly amazed me that could happen in this country. But that's the way it went. Fortunately, all charges were dismissed with prejudice, so that was good. Okay, so let's talk about the different kinds of diseases that we have to deal with, at least just briefly discuss them. I'll discuss NICO in a little bit more detail later on. Osteoradionecrosis, dry socket, you've all dealt with this, whether you deal with people with neuralgic pain or not. And so at one time or another, you've all dealt with these diseases. Let's just go through some of these very, very briefly. It's been known forever. You can read novels from the 1700s that talk about people who used to sniff cocaine. And cocaine is a known ischemic producer. It produces ulcers of the septum. And since these people are addicted, that doesn't seem to bother them or stop the habit. And so eventually the destruction goes through and through the septum, the cartilage is gone, and over a period of time, if the habit continues, it goes right through the bone of the hard palate. A completely painless process, like periodontitis, absolutely no pain with this. First time the patient knows there's a problem is when they blow their nose and a bunch of necrotic debris comes flying into their mouth. And so cocaine has long been known to be a producer of osteonecrosis. Syphilis and tuberculosis back in the 1800s and before that time, if you had a perforated palate, you had one of those two diseases. That's what physicians use to help with the diagnosis. Totally painless. Sometimes this isn't pus, this is just necrotic debris that's hanging down in this particular individual. Here's a torus in front. But these bugs seem to particularly like the interface between the cartilage and the palate, and so that's one of the favorite places for destruction of the skeletal system. And of course, now we don't have much tertiary syphilis. It seems as if tuberculosis is coming back in this country, and it's certainly fairly strong in many other countries around the world. But there is another example of osteonecrosis. There is something called midline lethal granuloma, which in the past decade or so we have discovered is a very special form of lymphoma. Remains very localized. There are some localized forms of lymphoma throughout the body, and this is ours in the head and neck region. It is very, very clear. There's something that is seen in HIV patients more than in other individuals, but its favorite thing to do when it gets started is blow a hole in the hard palate. And it can go on. We recently presented a case of the month in the Texas Dental Journal. You can see the kind of destruction that eventually occurs. Midline lethal granuloma is a good name for this. It destroys the entire midface and kills the patient because of local destruction rather than any kind of metastatic disease. It's a form of necrosis, osteonecrosis. Completely painless, I might add. And a look-alike lesion that often confuses us in pathology is Wegener's. Wegener's is a lesion that is a vasculitis, and all vasculitides cause some kind of problem with blood flow throughout the body. Lupus is probably the best example of that. And if you have lupus, you have a 1/3, 1 in 3 chance of having osteonecrosis somewhere in your skeleton, most likely in your hip and in your knees. But some of those are jaw-related cases. So this destroys very painlessly a lot of bone and perforates. It can destroy an entire palate, hard palate. And in this case, it's often a fatal disease. If we have this kind of destruction in the mouth, we're going to have much more in other organs, in internal organs. And osteoradionecrosis is unique in that we get exposed bone. The tissues just ulcerate, fall apart off the surface, and it will not grow over that bone. And we have known forever that what we have to do is use as many portals as possible, get that machine to go through uniformly all the bones, so there's no increased dosage at any one site. And so this is a disease that's now seen in less than 1%, maybe less than 0.5%. in individuals treated for tongue cancer, for example, whereas it used to be 15 to 20% of all of those individuals if you go back to the 40s and 50s and 60s. So it's much less common, but that's a unique thing. And this unique thing, exposed bone, that doesn't seem to, sometimes it's not even painful, but it can be extremely painful. The most recent form of that is also a chemotherapy-related thing, or a cancer therapy-related thing. In 2003, we found, we had our first examples of bisphosphonate-associated osteonecrosis. And to this day, we have no evidence that this is in fact an osteonecrosis. It may or may not be painful. What happens is somebody's on these drugs, and the drugs, the cancer-related drugs, are generally intravenous in nature. Zometa and Iridia are the two names. 99% of those drugs are made by Novartis, one of the biggest drug makers in the world, a Swiss company. I'm on their osteonecrosis advisory board, and I have been for about 4 years. And it's been a very interesting tour. All of this has been so obvious that it's taken a lot of the interest away from the neuralgia-inducing types of osteonecrosis. And we're slowly getting a handle on this. I agree it's osteonecrosis, but we truly have no microscopic proof. There's never been a single example that shows ischemic bone change. What we get in pathology is a piece of dead bone covered with bacteria and pus that you guys pick out of the jaw. And we never get the deeper bone, and I'm not sure it would be ethical to ask you to give us some deeper bone. But unlike radionecrosis cases where you just keep chopping away until you get into an area where the bone wasn't irradiated, the whole skeleton is involved in this case. And we don't quite understand, there's nothing in the physiology of those drugs that would cause bone to die. So there has to be something else, and we're looking at secondary triggering events right now. I'll talk about that if I have time a little bit later. Right now, the bisphosphonates, by the way, are also those osteoporosis drugs that are so popular, Fosamax. And we are running into 97% of all reported cases of this bisphosphonate osteonecrosis in the jaws have been in cancer patients, cancer drugs. However, we're getting more and more, and I expect that we'll find that we'll have maybe only 90% of them in the near future that will be cancer-related. The rest will be the Fosamax related. There has been an estimate that the chance of somebody on Fosamax getting osteonecrosis of the jaws is somewhere between 1 in 4,000 and 1 in 12,000. And that's a pretty low risk. But nevertheless, if it happens to your patient, and it's especially a painful variant of the disease, then it's a serious problem. There have been, I reported the first case about 5 years ago, or 3 years ago, there have been some cases of exactly the same thing without bisphosphonates. This was a 17-year-old girl I saw back in the 70s. I thought maybe she said she was using a lot of street drugs. I thought maybe it had messed up her immune system. But I'll bet it messed up her coagulation and blood flow more than her immune system. But nevertheless, she had an exposed bone produced by us. You can see the outline of a rubber dam clamp. It was placed a little too high. The dental student did that. And I followed her for about 8 years, and this never did get better. It never really caused a problem for her. But what I'm saying is there are now about half a dozen cases of bisphosphonate-like osteonecrosis with exposed bone of the jaws, but no contact ever with the drug bisphosphonate. And of course, you may or may not remember from your dental school days, if you go to some third world and fifth world countries where poverty is really endemic, there's a disease in kids that's very sad called Noma or cancrum oris, and that is a disease that affects kids after their immune system is depleted. Because this is mostly a protein deficiency, they'll get sick they'll have pneumonia, for example, and when they get off of the pneumonia and the parents are thinking, okay, my kid is going to survive, then this starts happening because the immune system has been depleted. It cannot be reproduced very fast because of their malnourished state. And it can go on to destroy most, if not all, of the face, the mid-face, and it can go on to kill the patient for a variety of reasons, mostly secondary infection. So that's an osteonecrosis that we've known about for a long time. We don't quite have a good handle on it. There is a form of disease that we've recently labeled idiopathic osteosclerosis. I think those are all, if we look at the long bone literature, They call those things secondary to infarction. This is a bony healing or response to wall off an area where there was an infarct in the marrow. And I think eventually somebody, maybe me, will start writing papers where I or somebody will say, we need to call this a more proper name. It's not idiopathic. We do know at least one cause, and ischemia is that cause. So ischemic osteosclerosis, it's just one of the things I think will happen over time. And then, of course, dry socket I won't get into because this is, you've all had to deal with that, but it is interesting. We thought it was an infection. Antibiotics didn't help. And we think that this is somebody in smokers who, they puff the clot out. However, in people who have looked at sockets and made some kind of correlation, nothing reported in the literature, but they say that they can almost predict because the blood that oozes out of that socket is so minimal and so thick. And I've seen a lot of that in NICO lesions where the blood is minimal and thick. And I think the socket was dried out even before the tooth was pulled in those cases. But that's yet to be proven. Why are the jaws so special? Well, probably the biggest thing is right here. If you think about it, you know lots of people with a tooth extraction. You know lots of people with endodontic treatment. You don't know that many people have had fractures so severe that the bone was shoved out of the skin and remained out of the skin for weeks at a time. But that's really what happens when we pull a tooth. Most of us don't, fortunately I don't do any of the surgery, but most of you, when you extract a tooth, you might ream out the lamina dura a little bit, but you're really leaving the socket and the bone exposed. And it seems to work fine. I claim that that's because of the wonder drug called spit. Really is, we've got one of the salivary proteomics experts in my department, and I am just amazed at really what good things spit does for us. So I think we get away with it. But I used to teach, I had a month, each orthopedic resident at West Virginia University spent a month in my office, and we do a little research project, and I do a little training 1-hour lecture every morning. And I'd always wait till the end, and then I'd tell them what dentists do when they extract a tooth. And every single one, I had 2 of those a year for 15 years, they all said, oh, how can you do that? That's malpractice to do that. And yet we've been doing it for hundreds of years. So there's a little different mindset in dentistry compared to medicine. But we have more trauma, we have more infection, and that infection is right next to the bone. I mean, it's just a couple of millimeters away, and you know that inflammation sends out inflammatory cells as well as the toxins from the bacteria. The inflammatory cells send out cytokines that are designed to kill off stuff. And yet we don't, I mean, we have periodontitis, but it doesn't seem to be the rampant, rapid destruction that you would expect from this kind of a process. But there's something else unique about the jaws. What other bone has vasoconstrictors routinely, maybe annually or multiple times during a year, injected either into it or adjacent to it? And keep in mind that the vasoconstrictors are designed to give you time to work, but they reduce blood flow for 50 to 70%. That's what they're designed to do. And the only way we get away with it is because it is only for less than 45 minutes. If you reduce the blood flow by 70% for more than 2 hours, that is almost guaranteed to cause a certain amount of osteonecrosis in that jaw. It just isn't readily evident right away. It may be months or even years before the real problem occurs, the pain problem. But nevertheless, that's another thing that's very unique. And also, we've got the teeth with all their infection, and we have tori. Tori, I'm doing a study, not published at all yet, but I have about 35 tori. And I'm treating them like research grade bone and decalcifying them very slowly so I can evaluate whether the bone is alive or dead. And about 40% of them have large areas where there are no bone cells. There's dead bone within them. And so I suspect, and this seems to be correlated with age, I suspect that that's an aging phenomenon, that we just don't have good blood flow through a torus, a typical torus. So they're susceptible. And probably another very unique thing that is related to NICO or this neuralgia type of pain from ischemic bone problems is this last item. There is no other bone with large sensory nerves. Every other bone in the body, you can, once you cut through the cortex, you can slurp out the entire marrow without any anesthesia. That's just the way bone works. But of course, we've got teeth, and even after the teeth are gone, we have the nerves remaining in the jaws. So any disease that occurs around those nerves, even if it's just air, one of the torture techniques used during World War II was to rip open a nerve and just leave it exposed to air. It's one of the most painful things they could do to individuals. And if you've looked at some of these cavitations or ischemic holes in the bone, I've seen several where the nerve, it's all frayed and brown, and looks pretty ugly, but it's dangling, coursing right through clear air. And that's got to be a painful condition or pain-producing condition. And if that's not enough to make you think, look in the literature, you'll find that textbook literature, this would be, that about 80 to 85% of all the neuralgias in the body are in the head neck area, mostly the face, mostly the trigeminal nerve, and that's one hell of a nerve. We have, as a sensory, it takes up, while you're awake, it takes up about 40% of all your brain power that's dedicated to sensing things around you. And it's certainly not 40% of the number of miles we have of nerves in our body. So it's an impressive nerve to work with, and in dentistry we work with it all the time. We don't seem to get too upset by it, but it's a whale of a nerve. But this whole disease of ischemic bone disease is fairly new and requires that we have a new way of thinking. And I just wanted to point out that, well, this isn't. This is supposed to go somewhere. Well, it's a great picture. It is a picture that forces us to rethink our way. If you look at it the way it is right now, it looks like a frog, but the picture was supposed to rotate to the counterclockwise direction, and then it looks exactly like a horse. And there are some people who can't, depending on the picture, the direction of the picture, they can't see the other animal in that picture. So I'll let you use your imagination. If you can't see a horse, I guess you don't have much imagination. So I'll give you another horse. It's just a great picture, but it reminds me to let you know this is a local manifestation. All these ischemic diseases are local manifestations of systemic problems, maybe systemic origins. And so we have to deal with medical people as well as other people who are just worrying about the rest of the body, not just the mouth. And that seems to be kind of one of the standards for this organization. So let's look at some of the things about ischemic bone disease that we know from the rest of the body. We know that it's been around for a long, long time. The first case in the hip was reported in the 1700s. It was reported under, actually it's about 72 or 73 different names. In Germany and Austria and Hungary, there were all kinds of docs who would say, well, they found this disease in this bone. So from that point on, the disease was called after that doc's name. And after a while, the disease turned out to be the same. But it had all these names because surgeons were writing the articles and no pathologists got involved until the 70s. And then they looked at the tissue samples and realized that this is all the same stuff. And since that time, it has become one disease and we've lost almost all the other names. Another thing that's happened since the 70s is we have found that, as a matter of fact, even though anybody who does research in ischemic osteonecrosis uses this now as an umbrella term, and there are subsets of the disease. It's not just dead bone. Avascular necrosis means only dead bone, but depending on who you're talking to, if you say ischemic osteonecrosis, yes, we know the word osteonecrosis means dead bone, but that's not the way it's used by people who do research in that. And these are considered to be subsets of ischemic osteonecrosis. In my biopsy service, the bone marrow edema is probably the primary disease that is diagnosed in people who send in something with a NICO-like clinical diagnosis. Regional osteoporosis, transient osteoporosis are very interesting concepts, and I've seen this, and we have something called focal osteoporotic marrow defect, and I've looked at 600 cases of these, and I found ischemic change. Not major change, not major damage, but ischemic change in, I think, about 80+% of those. So I think that probably is also related to poor blood flow. One of the things that is very interesting about all these ischemic diseases is the overlying tissue doesn't get red, doesn't get swollen. It might hurt, depress, but that's about it. And if you look at all of these, regardless of the bone involved, whether it's the jaw, the hip, the knee, 2/3 of them are painful, but that means 1/3 of them have no pain. And in the hip, that means a person can be walking along and the entire hip collapses. The inside of their femoral head is mush, and yet they've had no pain up to that point. And I've also seen NICO cases with just a 2 mm area of involvement that seemed to be the culprit, the pain producer. When that was scraped out, the pain seemed to go away. So it's a very frustrating and fascinating disease process. And one of the things that we have to always keep in mind, some of you in back can't see that bottom line, but it says 50 to 80% are bilateral and multifocal. If you have bone marrow edema of the hip, which is now an MRI diagnosis, remember, if you have it of the hip, you have probably an 80% chance of having it within the next 5 years in the other hip. And multifocal means in the same jaw, you have a spot of involvement here, and then you have some good marrow, and then a spot over here, another spot over there. And diseases tend not to do that. Diseases tend, especially infections, tend to coalesce. They have one center, and it goes out in all directions. Ischemic change doesn't do that. And of course, what we see is pretty obvious, but it's not seen grossly until somebody has their femoral head replaced. We get this mushy, brownish material. This is relatively normal. This yellow is relatively normal, but we see an area of involvement, and probably we've had some crushing of the surface cortex and certainly some thinning. And sometimes yellow chalky material is part of the same process in hollow spaces. There is now a lot of literature on this disease. A lot of the orthopedic surgeons have a textbook. They asked me to be a co-author of one of the chapters, and that textbook devoted to this disease. And they seldom publish their own textbooks, but it became such an important topic for them that they decided to do that. Well, the stuff... Oh, did you hear that? I was being cute. I set this slide up to chime, so now I thought that somebody was giving me a signal to get off the stage. But let's see if we have a jawbone equivalent. This is normal bone. It's sort of a cut through the anterior mandible, and you see it's all nice yellowish white, and we don't have very large hollow spaces, maybe a little one here. And these are examples from that autopsy study that I did, or cadaver study. My assumption with that cadaver study was that I want to look at those mandibles because nowadays people who donate their bodies to medical and dental schools, really are people with chronic conditions. They've had a heart attack, they've had cancer, and they take months and months to die in the hospital or maybe at home with hospice care. And the medical staff gets a chance to work on them to get them to donate their bodies to help people learn. And it used to be, back when I was young, that the only bodies we had were, not only, but primarily were Skid Row, John Does and Jane Does. And now ethical requirements don't allow us to use those bodies. So I thought, well, this should be a very good group. I would expect many of them are ischemic, the whole body's ischemic at the time of death. And I found about a little under 1/3 of those mandibles had evidence of ischemic disease. So these are some of those. And here's this brown, mushy material. You see the tooth is involved and has some brown discoloration of the root tip. I've had people tell me about that. I've seen some that were sent to me with that. And here's brown involvement, even up into the TMJ. And we have some literature. I haven't updated it. I'm in the process of writing another review articles, but I haven't made the numbers. But I did this for a trial, and this is as of 2004. There were 23 textbook discussions, including the Bible of Oral Radiology. That hasn't been updated, however, since then. The Bible of Oral Medicine, that has been updated since then. And we have about 150 publications that are peer-reviewed, either in abstract form or full peer review. So there's information in the literature, and that's important. However, it's very frustrating because people with this disease say it doesn't exist, and in discussion with them, I'm open. I'll discuss this with anybody. But I find one of the first things I do is find out just what they've read. And I have yet to find one person who had that opinion, this anti-NICO opinion. One person had actually read an article about it. Everybody else, no. And to this day, if one of my colleagues in oral path wants me to come to their school or their center and bring a bunch of these cases microscopically and discuss them, I've always done that, and I've never left that without them knowing what are the criteria, microscopic changes. So the histology is pretty well established right now. It is loose. It's like inflammation. This is not a specific disease. This is a disease process that can be part of lots of other diseases, including diseases brought on by medications that our patients are taking. Bisphosphonates are the latest thing, and as of this year, we had a conference call about a month ago for Novartis, and they had counted over 170 articles just on that disease alone. I'm not going to go through this in any great detail, but I should say that this is part of a handout. I can't give you my discussion because I have some of these hip cases that are taken from textbooks. However, if you want, I have what I call the NICO handout. It's a PowerPoint presentation that I could use for a 4-hour lecture if I wanted to. And I make that available. All those slides are mine to do with as I wish, and your organization now has the latest version of that. I also have a similar copy of the microscopic features of ischemic bone disease. Those are all my pictures. Your organization has a PowerPoint presentation of that. And as a bit of a bonus, I've given them the latest version of the 53 most common lesions. And that is something I made available to the world about 3 years ago. And I would estimate that tens of thousands of people have used them. There are 160 clinical pictures of very common lesions. It's the kind of thing where you can make up your own lecture from those pictures, but they're all listed according to frequency of or prevalence rates. Well, just to let you know that we've been dealing with ischemic bone disease a long time. Back in the 1859 and even before that, there were some hints of something that the dentists were talking about. Eventually, they found out that phosphorus, mercury, arsenic, lead, and tin were in were the probable culprits for this. But what would happen is a patient would come in with a toothache, and the dentist would, they didn't have x-rays then, the dentist would pull the tooth, and large chunks of the mandible or the maxilla would come out with the tooth. And these were individuals who had intense pain, much worse than the typical kind of toothache. And eventually, they just figured it out by themselves. There was no scientific study to prove that this was true, but this was a time when phosphorus safety matches were just being made. And in the East Coast, Philadelphia in particular, it was a major cottage industry. The husband would go off to a factory and probably get tin or lead or arsenic poisoning, and the wife would bubble phosphorus and dip wooden sticks into it all day long in the home. And so there were reasons for this to happen, and it lasted until about 1900, and then it seemed to disappear. And as early as 1868, Knoll, a dentist, this is all from the dental literature, said that, hey, there are two kinds. There's one that kills the bone and one that leaves the bone pretty much alive but diseased. And that's exactly where we're at today in our understanding of that disease. And Ferguson, in the same year, said, well, I think the best way to treat this is think of it as osteomyelitis and just go in and scrape everything out and cross your fingers. And that's kind of what we do today. And G.V. Black wrote about it in 7 pages of this disease in 1915, including one case with a 5-centimeter hollow space in the mandible. And Box was very influential. He was from the University of Toronto. And what he did was especially talk about the type of pain, but also these residual sockets. 20, 30 years after a tooth was pulled, you could still see the lamina dura in place, maybe perfectly in place, and that just doesn't happen. Bone physiology will not allow that to happen. When you remove the stresses in a bone, it may take a year, 2 years to change, but it is designed to change to meet the new stresses. And if you don't have teeth, then that bone should remodel. And if you see a residual socket, it doesn't give you a diagnosis, but you at least should be thinking there was something wrong with this patient even when this patient was young and had those wisdom teeth removed, for example. And then Ratner and Roberts, when I first got involved, these were called the Ratner cyst and Roberts cyst. I first got involved, gave my first talk in Ireland in 1989, and I decided to call this osteonecrosis instead of osteomyelitis, mostly ischemic problem instead of infection. I didn't know what to call, I didn't know how to pronounce it. I was going to call it NICO, like Nike shoes. And I was wandering the streets of Dublin late at night, and a lot of faculty people were doing that. You're given only 12 or 13 minutes to give your talk, so you have to memorize the whole thing and make sure that you can do it in that time. So there's nothing spontaneous about those. And the streets of Dublin every night were just covered with people walking back and forth and kind of mumbling to themselves. It's very strange. But I was doing that. I've only done it during about that time. I quit doing it and just winged it after that point. But nevertheless, I was walking along and I saw this restaurant called Nico's Restaurant. Went in, it was an Italian restaurant, and I had some spaghetti and asked them how to pronounce the restaurant. And they said, Nico, it's a nickname for Nicholas. It's a Greek nickname also. So now I know how to pronounce Nico. From that point on, I knew how to pronounce it. And as soon as the O changed from osteomyelitis to osteonecrosis, then the question becomes, well, how do I diagnose this? It's so hard with x-rays, especially the irregular jaw x-rays. And so I went into the orthopedic literature of that time in the 80s and early 90s, and it was all about Tech 99. The original scintigraphy, or the original bone scan, radioactive isotope bone scan, was the Tech 99. And it was the MDP, and that happens to be the one that attaches to the bone crystal. And so it's still the best for the jaws. But MRI has proven to be much more successful in those big round balls on the ends of the knees and the hip joints. So I think Tech 99 is still a very useful tool. It's expensive, however. It's about $700, and there's a certain amount of morbidity associated with that. It's small, but it's still there. When I got involved, I thought, well, you know, nobody's ever given a microscopic description, so I'll do that. And it wasn't my best paper, I'll admit. I can do a much better job now and hope to do that. But shortly after, Bob McMahon, completely independent of me, I really met him about that time, wrote a paper on diagnostic anesthesia. And he said, look at this. I had 48 patients. They all had pain. They all had an area of tenderness. I put the injection, just a little dab of anesthesia right where the center of tenderness was, and then I did a biopsy under that. And every single one was either osteonecrosis or osteomyelitis. Every single one. He had a pathologist from the medical school, Indiana University, doing that, helping him with that. And so I've come to really trust diagnostic anesthesia, but there's so much, the trigeminal system is so complicated that there are foolers that have fooled me on several occasions. Oh, I should mention that back in the 90s also, major breakthrough was that we found that 72%, now close to 80% of all osteonecrosis cases in the jaw have clotting disorders. And that's exactly the same percent of patients who have hip disease, hip osteonecrosis and knee osteonecrosis. And that's through two centers, the University of Cincinnati as well as Indiana University. And fortunately, we had an associate dean at Indiana University as our expert on coagulation. So that's been confirmed several times, but it's kind of, nobody's doing much in that area right now. And just as a study, we wanted to know how much of this pain is produced by this sluggish blood flow. So Dr. Gluck, who's got about 800 papers to his name, and was so much anti-dentist when I first met him that he refused to talk to me. He wouldn't let me come and talk to him about a research project. And I only fooled him by making an appointment with his secretary and just showing up. And he was literally coming out of his chair to throw me out of his office. That's how we started our relationship. But we are getting along just fine now, and he's very much convinced that this is a big part of the pain in all of these conditions. He gave the appropriate coagulation, anticoagulation medicine, blood thinner, to these patients, a fairly large group of patients, maybe close to 50. And over 40% had the pain totally disappear with nothing else, just blood thinners, nothing else. And so I guess we can deduce from that. That was just a pilot project. It hasn't been expanded, but at least it suggests that a bunch of this pain is due directly to the poor blood flow in these jaws, not to anything else that's going on. And then Don DiNucci was in the maxillofacial pain area of NIH, and he was assigned this task. I was telling people NIH that you should do Tech 99s on people with atypical or odd facial pains and see what's there. And he did it on 21 patients, I guess, 24 different painful sites. And he was going to prove me wrong, but it turns out 75% of those patients had a hot spot exactly where the pain was. And they did no biopsies to prove anything beyond that point. But I decided to try to confirm that, and in 2004 I reported that 79% of about 117 patients with over 200 areas of facial pain had hot spots in that area of facial pain. And Bob Jones got me involved in ultrasound. I started that in 2001. And it was my data, I guess, that got the FDA approval. So I had the FDA people at my door, and I had to go over there several times. They looked at all the raw data. I was very impressed by the investigators. I had 2 uniformed investigators show up in my office on 1 day's notice saying, we're going to be here for a week. And I was never so happy to see anybody leave. And they sent a nice letter saying that we found absolutely nothing wrong. And the data showed that ultrasound is very good for finding hollow spaces, very good at finding dry bone, very good at finding low bone density. That's what it's FDA approved for. It's been abused. I've had people say, look at there, you've got NICO, because this ultrasound says that you have. And it doesn't diagnose NICO at all. It just diagnoses, it's like a Tech 99 scan. It gives you some idea that there's something wrong in that particular area. So it's been an interesting journey that way. Well, let's look at etiologies. If we look at the long bone, these are the general things that we look for. You see infection and trauma are high on the list. Estrogen therapy, there is a disease called estrogen-related osteonecrosis. There's a disease called corticosteroid-related osteonecrosis. I didn't put it on here, but deep sea diving or working under pressure in making tunnels, caisson's disease. If you are a Japanese pearl diver today, using the hard helmets, that kind of deep diving, you have an 80% chance of having osteonecrosis in your lifetime. Okay. And so it's called associated hyperbaric osteonecrosis is the term for that. I've already talked about malnourished problems. Probably the correlation with lupus is they've got a couple of antibodies that mess up coagulation in those individuals. And of course, radiation and chemotherapy are also part of that. Anybody who's got cancer in their body, the cancer is putting out molecules that mess up coagulation. And by messing it up, it usually means increased coagulation. And bisphosphonates we've talked about. And the problem with this is this requires multiple, it's like cancer. You have to have multiple steps before the final endpoint. And it may take 30 and 40 years for that final endpoint to happen. Same exact concept. So Sod's second law, sooner or later, the worst possible set of circumstances is bound to occur. That does hold for this disease or these diseases. However, I think most of us go to our grave without having any major problems when we have these coagulation disorders and even bone involvement. Osteonecrosis used to be considered really rare. Now it's responsible for more than 40% of all hip and knee replacements in this country. And if you have osteoarthritis, my knees are pretty well gone. I was told I definitely need replacement. And in people with arthritis, such as myself, but you can almost guarantee that they have bone marrow edema beneath the diseased cartilage. And there's one animal study that shows that, in fact, the bone marrow edema might be drying out the cartilage beforehand. That's the first thing that occurs. So it'll take some more time to find a real correlation there. And now about 80%, regardless of the bone involved, these individuals with osteonecrosis have a hypercoagulation state, either excess thrombosis or an inability to break up thrombi as we go along. And here's a nice example from a jawbone, but it's still the same thing where there's a clot completely plugging a vessel. So is there a jaw equivalent? First of all, you should know that in this room probably, well, according to Red Book, we have maybe 1 out of every 5 of us with these hypercoagulation states. I was just diagnosed with one, elevated cysteine. They're mostly inherited, but they can be influenced by environment, by diet in particular. And I think if we look at the scientific literature, it's somewhere between 8 and 12%. The latest one was 15% of us have hypercoagulation states. That means we're susceptible to this. And while we're young and our vessels are nice and slippery, that's fine. But as we get older, things don't move as well as they used to. We get atherosclerosis on top of this. And it's just another factor that causes some problems. But with hypercoagulation states, the biggest problem is small clots. These don't throw large clots. Well, they don't. They can, but they usually don't. And small clots affect the bone marrow, fatty marrow, more than any other tissue, so besides the brain. So that seems to be one of the reasons that, or one of the correlations. Well, do we have this in the jaws? Here we have the latest figures I've gotten from the University of Cincinnati and the NICO patients is, and this is many hundreds, 78% have a variety. This is, if I send a patient to them right now, they'll do 16 different tests. And why didn't we know this before the 1990s? The tests weren't available. We didn't know about hypercoagulation states. We knew about all kinds of blood clotting problems and diseases, but these are states that make you susceptible to additional diseases like osteonecrosis and deep vein thrombosis and even stroke. So these are out there now. We have the tests for them, therefore we can have a disease produced by them, or at least a disordered change. I won't get into, well, let me just show as a final point, whoop, it seems to be going, okay, sorry about that. This disease is called cavitations by maybe a lot of people in this room. I have to tell you, I hate the use of that word. The other research disease I work in is leukoplakia, and I hate that word as well. They're both nonspecific, and I have to know the person to know what definition they're using. I've had people use cavitation. I went to Alaska to help defend a guy who was accused of, they wanted to take his license away for doing cavitational surgery. And what his definition was just reaming out the lamina dura after he extracted a tooth. That was cavitational surgery for him. So I never know. But the true definition of cavitation in the orthopedic literature is a hollow space in the bone, pure and simple. And the word has not been used outside in the orthopedic literature. It has not been used for any other disease except ischemic osteonecrosis and its variants. Here are some examples in the hip. You see little fracture lines or fairly large fracture lines. This probably collapsed to a certain degree. And this is a collapsed hip that didn't get repaired in time, so there's a little bit of attempted repair. But you see these cystic spaces can be multiple, scattered with normal bone between them. And here is, I think, a rib that shows how localized this disease can be. And here is histologically, we have perfectly normal fatty marrow up here, and then down here we have this subtle fibrosis, weaving of fibers in between the normal marrow spaces. And osteonecrosis is becoming a fairly major part of osteoporosis, as a matter of fact. And I told you that there are some individuals who think that these variants of osteoporosis really are a form of osteonecrosis. It's an ischemic problem more than anything else. So what equivalents do we have? We certainly have. Those of you who have done this surgery, this is Wes Shanklin's case. This was a lawyer who donated her jaw to Wes, and I processed it for him, but this is immediately after he took the cortex off and then put it in the formalin. And he didn't touch any of it. These holes were all here beforehand. And some of these hollow spaces are probably poorly healed sockets. Others seem to be much more extensive than that, and I assume that maybe when a tooth was pulled, the increased trauma to that area led to infarction, and one infarction would lead to another one adjacent, and it's a sort of a process that seems to go on indefinitely, becomes self-perpetuating. I told you starvation, malnutrition is one of the major causes of poor blood flow to the bone. And the reason, by the way, the bone is very susceptible is the blood has to move upstream. The pressure inside the bone is higher than the pressure outside. That's the only tissue that has that situation. But Recently, I helped somebody back at West Virginia University in their master's thesis, and I just happened to just be with him when he had all of these bone mandibles. As my departing point, I can tell you that you can buy a mandible. I don't know where they come from, but you can buy from international companies a mandible for $75, a human mandible. I would have thought that would be so against the ethics. I offered some of my mandibles to the university to work on because I did them all through proper channels and got them all through proper channels. And they said, no, we just have to get $75 a piece. But it was nice. These were all dried, and I just want to show you. This is about normal. Here's a ramus. The normal trabecular pattern in the mandible, they're plates more than they are just tubes. But here's a hollow space inside this mandible. And here's a hollow space. It might be a residual socket. This is a residual socket maybe. Here back in the ramus is a hollow space. And you'd expect that, wouldn't you? Because starvation, poor nutrition is one of the features that produces these kinds of jaws. And I would expect that these jaws are being harvested from the poorest of the poor in whatever countries they come from. So I've got a little bit of histology I was going to get into, but I spent too much time. I knew I couldn't do this in an hour. I'll be around this afternoon if anybody has any questions, and I think we have a little session at 4:30 also if you have questions. So thank you for your attention, and I appreciate being invited.